afternoon. Thank you for attending this month's OCHIN Grand Rounds. I am your host, William Pinnock, and today I could not be more excited to have Dr. Joanne Sperl-Hillen of Health Partners Institute and Dr. Rachel Gold of OCHIN and Kaiser Permanente Center for Health Research here to present the impact of the CV Wizard clinical decision support / shared decision-making tool on cardiovascular risk management in CHCs, results from a large clinical trial at OCHIN. Dr. Joanne Sperl-Hillen is a senior research investigator at Health Partners Institute. Her work focuses on improving outcomes for patients with diabetes and chronic diseases through approaches that include use of information technology and electronically captured health data to facilitate better decision-making between providers and patients, strategies to support patient adherence to recommended treatments, and better ways to engage and educate providers and patients. She conducts healthcare delivery research and clinical trials in diabetes, prediabetes, hypertension, lipids, cardiovascular risk reduction, cancer prevention, and opioid use disorder. Dr. Rachel Gold is an epidemiologist and health services researcher. Her work focuses on using health information technology to improve care quality in public clinics and the implementation methods needed to support adoption of such technologies. Dr. Gold has partnered with the OCHIN Practice-Based Research Network since 2005. She now has a joint appointment at the Kaiser Permanente Center for Health Research, where she is a senior investigator, and OCHIN, where she is the lead research scientist. Her work includes studying how to implement a multifaceted quality improvement initiative that improved cardiovascular disease and diabetes care in the Kaiser Permanente setting. She's also studying the adoption and impact of an innovative point-of-care shared decision-making tool on cardiovascular disease outcomes in community clinics. She also pilot tested electronic health record-based tools for collecting and acting on patient-reported social risks, and is now studying how to help community clinics implement systematic social risk screening and how to use patient-reported social risk data in clinical decision-making. This session is being recorded. Attendees are muted upon entry, but if you are not, please mute your microphone and pose your questions through the Q&A or chat box. This presentation will last approximately 45 minutes, with 10 to 15 minutes at the end to answer any questions you may have. We will now pass the mic to Dr. Joanne Sperl-Hillen and Dr. Rachel Gold for the impact of the CV Wizard clinical decision support / shared decision-making tool on cardiovascular risk management in CHCs, results from a large clinical trial at OCHIN. Dr. Gold, Dr. Sperl-Hillen, the floor is yours.
Thanks, William. Can you hear me?
I can.
You can hear me okay? Great, okay. Thank you everybody for allowing me to have a few minutes to present to you some information about Priority Wizard, which Rachel's going to go into some more detail on a study of using this tool in the community health clinics. But I'm going to just first go through some background slides so that everybody has kind of a good handle on what this tool called Priority Wizard actually is. Next slide. And so Priority Wizard is a shared decision-making system that we have integrated with Epic. It technically could be used in other electronic health records, but most of the way that we have implemented this thus far in care systems has been to integrate it with Epic. It's been developed at Health Partners Institute through federally funded research projects. And its intended use in the projects where we have implemented it is for primary care clinicians to use it at encounters with patients to make decisions about cardiovascular risk factors. Through NIH funding over the last 15 years, we have expanded on the clinical content. It started out being a diabetes clinical decision support tool, and then expanded to include all of the cardiovascular risk factors. And we now have ongoing research studies to expand the content even further to include opioid use disorder, cognitive impairment, chronic kidney disease, medication adherence, weight management, and more. It's being used all over the Health Partners family of care, which includes clinics across Minnesota and into Wisconsin, as well as at Essentia, which is rural Minnesota and in North Dakota, and in these federally healthcare qualified safety net clinics through what Rachel has done with OCHIN. And we have a number of clinical trials that I'll talk about a little bit later that have demonstrated improved outcomes for patients with this tool. Next slide. So how does Priority Wizard work? Well, first of all, at an encounter, it will recognize individuals with the greatest potential for cardiovascular benefit. We aren't interested in trying to promote the use of this tool in patients who don't have reversible risk. So they need to have something actionable for us to try to promote the use of this tool within encounters. And so we use the gold standard ACC-AHA risk estimator to calculate a person's cardiovascular risk. And then we determine from that if they were to be at goal for all of the indicators that go into the ACC-AHA calculation, how much would their reversible risk be? How much could their cardiovascular, 10-year cardiovascular risk score be reduced if they were to be at goal for all of their cardiovascular risk factors? We then order the cardiovascular risk factors from the highest to the lowest priority based on the potential benefit for an individual patient. And then we have a number of algorithms that are hosted in a web-based server that are based on national guidelines to personalize some treatment recommendations for patients based on the EHR data. And that includes their medications. There may be suggestions around behavioral or lifestyle change, safety issues or alerts if they're identified, referrals to consider, or tests that may be due for monitoring, such as A1Cs. This information is all compiled and summarized in one tool, and we provide a summary printout, one-page summary printout for patients and one for clinicians. And between these two tools, we hope that these things support patient engagement and shared decision-making. And we try to provide this information at the beginning of the encounter. So all of this is triggered upon blood pressure entry by the rooming staff. And we hope that these materials are printed by rooming staff for the clinicians to use, because we know that from previous work that we've done, that clinicians really value having these tools printed for them rather than having to take the time to do it themselves during their valuable encounter time. Next slide, please. We have a number of principles by which we've built Priority Wizard. The number one principle is that it has to be evidence-based. So all of the clinical decision support content in the recommendations and the algorithms that are behind those recommendations are based on national guidelines. And we have content experts that work with us both in the development of these and also to keep these things up to date. So as guidelines change, new evidence emerges, we try to be very prompt in modifying the algorithm so that clinicians can always stay up on the most recent evidence base. Our both Patrick O'Connor, who is a co-developer along with me in this tool, come from a primary care background. And we realize how precious time is during an encounter. And so one of the things that we have always believed in is that these tools have to be patient-centered, person-centered, rather than disease-focused. So a clinician isn't going to have time to run to 5 different clinical decision support tools for 5 different clinical conditions that a patient may have. So it's one tool for each patient that prioritizes the things that will matter most for that person. And the clinical decision support suggestions are tailored for that patient. So they're based on how far that person is away from their goals, what other comorbidities they have, allergies, what their lab values are, previous procedures, and safety things. All of the algorithms have these elements programmed into them. And the other thing that we have learned through the last 15 years of doing research is that these clinical decision support tools are not going to work if they don't get used. And there's a lot of literature out there of failed clinical decision support tools, not because they weren't really good tools, or evidence-based, but they just didn't get used. And so we have worked really hard to come up with a recommended process for using Priority Wizard, which is a standardized process for the rooming staff to print these patients for targeted patients, the patients that are in most need of cardiovascular risk reduction and diabetes improvement. The handouts are available at the beginning of the encounters, as I mentioned before, to promote conversation about the priority conditions. And we also, everything that we do is targeted at increasing clinician efficiency. And we have integrated the clinical care recommendations now into active guidelines that help clinicians quickly order any of the labs, meds, or referrals that are suggested by Wizard. And we're working on real easy access to patient educational materials as well. Next slide. This is an example of what a patient view of Priority Wizard can look like. And so when this gets handed to a patient, at the very top, it says, talk to your doctor about how you can improve your health. And and for this patient, tobacco is the number one thing. The greater the number of red symbols, the higher priority it is for that patient, meaning the most cardiovascular risk reduction could be achieved if they were to work on tobacco use for this particular patient. So the things with 3 red symbols have the most potential to improve health. And then the yellow symbols are things that need attention, usually tests that need to be ordered or are only minorly out of balance for that patient. And then the green check marks are things that the patient is doing well. We purposely designed this patient form to be something that a patient with low literacy and numeracy can understand. So there aren't a lot of numbers on here other than what their values are for LDL and blood pressure and A1C and such. Next slide. The clinician view is completely different and meant to really complement the patient view. So for an individual patient, you would see the same domains listed. This is a different patient. So for this patient, lipids and glycemic control are the things that are most important for this person to work on. But there's a lot of numbers on the page for this. It's intended to give clinicians all the information they need in one page to be able to have a conversation with patients about what they might need to do to improve these cardiovascular risk factors. The top of the form includes the 10-year cardiovascular risk score. It's the same score that a person would get if they were to enter all of this data into one of the online calculators that are available through ACC/AHA. It includes some relevant conditions. For example, if the patient has diabetes or heart disease, those things would be listed at the top. And then it provides treatment considerations and alerts that are based on national guidelines from the algorithms that are programmed in Wizard. So it has all their lab values, their meds, comorbidities, just almost everything that a clinician would need to know to have a conversation with a patient about these things. Some of the clinicians also do give this form to their patients who are high literacy, and some of the clinicians really prefer to use this form over the patient form with patients. Next slide. So the way that we approach implementing Priority Wizard in a clinic system is first, we review all of the algorithm content with the clinical leadership at a care delivery system to be sure that the Wizard content is consistent with their recommended clinical practices. And typically we've had had to make very little modifications because we're staying so close to the national practice guidelines. But we do occasionally customize text or change things based on reviewing the algorithm output with the clinical leadership prior to implementing in a care delivery system. And then we have WebEx or in-person trainings for the end users at the clinics to learn about Wizard, get them excited about it. And then we also will periodically provide refresher training. We monitor the use rate, so every time for an eligible encounter, if a best practice alert pops up for the rimming staff to print materials for these high-risk patients, we look to see how often the materials are actually printed. Because again, we know that if the information doesn't get put in front of the faces of clinicians and patients, it isn't going to do anything. And so we're always striving to achieve high use rates, and we provide feedback to the clinic so they know exactly how often these tools are being printed for high-risk patients. And then we also, if you click on the Wizard within the electronic health record and look at the online display, there's an operational manual that can be viewed. This is a new addition. I'm not sure if you guys have that at OCHIN yet or not, but a new addition to this now is when you open up Wizard, you can look at an operational manual. It outlines everything that's in Wizard. So if you ever have any questions about why a treatment recommendation is appearing or why, what's going on, you can really dig into it if you have the time or inclination to do that. Next slide. So we have a series of published RCT studies that have demonstrated improvement in situations where Wizard has been used in intervention clinics compared to control clinics. And we've seen improved glucose control in people with diabetes, higher achievement of blood pressure goals in people with diabetes. In people without diabetes or heart disease, but high reversible cardiovascular risk, we've demonstrated reduced cardiovascular risk scores in the population after 12 months. And we've seen the strongest benefit in tobacco users in that study. Also just recently published in JAMA, we did a study where we implemented the priority Wizard in patients with serious mental illness who had cardiovascular risk factors that were in suboptimal control. And the reason this is important is that patients with SMI, bipolar disorder, and schizophrenia have very high cardiovascular risk and tend to die at least a decade earlier than their peers due to mostly cardiovascular events. And so we were able to show in that population that we were able to reduce cardiovascular risk, and that was just recently published. Also in that study of interest was that the greatest benefit was seen in the non-white population. So there's a potential, we believe, for the use of clinical decision support, which is completely standardized and kind of removes some of the biases that may be present in clinical encounters. And maybe some potential there for reducing disparities. And as Rachel is going to talk about this next study of, what we saw in federally healthcare qualified clinics. And next slide. We've also done attempted a number of ways to look at what do patients actually think about cardiovascular Wizard. And one of the things that we did at Health Partners was a My Voice survey, which was showing people the output of a priority Wizard tool on a survey and asking how likely they were to take action based on the handout. And over 63% of the panelists said that rated their likelihood of taking action based on it as 8 to 10. And I mean, this is really compatible with the results that we see, because if patients weren't taking action on the handout, we wouldn't be able to see the kind of results that we see. Next slide, please. And before I turn it over to Rachel to talk a little bit more about the studies that we've done in the community health clinics, we do have a little disclaimer that that priority Wizard suggestions are based only on the electronically available data. And so when we go out and train clinicians on using this, we make sure that we emphasize that it's not intended to be a substitute for clinical judgment. It's not meant to be used alone. It's meant to be used with clinicians and along with their clinical judgment. So the clinician still needs to review allergies, follow product labeling, and instructions before accepting or choosing any of the treatment suggestions that might be provided on the Wizard tool. So Rachel, I'm going to turn it over to you now.
Great, thanks, Joanne. I'm going to share my screen. And this just takes a second. This is where the magic happens. All right, can you see my screen, William?
I can.
Yep.
Okay, great. Okay, so I'm gonna thanks, Joanne. I'm gonna talk. That's such a nice lead up to this part of the presentation, which is in which I'm going to talk about what we found using CV Wizard, which is the cardiovascular focused version of Priorities Wizard in community health centers. First, just want to give a big shout out to the team. We had folks on the team from Kaiser Permanente Center for Health Research, OCHIN, and Health Partners. This is a fairly big team. We had a lot of work to do, and a lot of really terrific collaboration went on to make this happen. All right, so the gist of why we did this study of CV Wizard in community health centers was we know that cardiovascular risk management is not where it needs to be nationally, and this is especially challenging in the socioeconomically vulnerable patients who are seen in community health centers, and that's for lots of reasons. But one of the reasons is that in these brief encounters, clinicians have to identify all these different factors that are impacting a patient's risk, figure out which ones are modifiable, which one's the top priority for that patient, what's going to have the biggest impact in this limited amount of time. That's a pretty big cognitive lift to ask of anyone. So clinical decision support systems or also and shared decision-making systems, as Joanne noted, can alert patients, alert clinicians if a patient has uncontrolled risks that could be modified, suggest up-to-date treatment options, and provide and support the patient-provider discussions about patient preferences for what they want to do to manage their CV risk, which is known to be an effective strategy for improving risk, is patient engagement and shared decision-making. But most of the prior research on tools like CV Wizard, including CV Wizard, have been done in well-resourced care settings like Health Partners, where for example, all the patients are insured by definition, or most patients are insured by definition. And when Patrick and Joanne and I first started talking about this, we thought, well, what happens in community health centers with a tool like this that has demonstrated impact in a place like Health Partners? What will the impact be in community health centers? Where we're starting with a patient population who have higher rates of uncontrolled CVD risk at a population level. So we conducted what is one of the first clinical trials to ask, does a clinical decision support / shared decision-making system from an integrated care setting also improve outcomes in CHCs? And I suppose I should note that this work is funded by NIH National Heart, Lung, and Blood Institute. So just a quick, again, reminder about what CV Wizard does. It targets reversible risk factors. Again, so we all get older. That is not reversible. Developed at Health Partners, but it's essentially managed algorithm. It processes EHR data, looks, and again, in Health Partners and some of its other collaborators, it was shown to improve glucose control, blood pressure control, reversible CVD risk, and it is really an amazing system. I think much better than anything else that I've seen. It's the algorithm. One of the cool things about it is that as new care guidelines come out, it's centrally organized. The algorithm is managed centrally. So rather than every different system or clinical system needing to update their algorithm every time, every time that something new comes out, it can be just one place. We were able to get new blood pressure information, for example, put in a CV Wizard within a matter of a month or two, rather than taking years and years. It's got both a patient and provider facing summary that is a tenet of doing of shared decision making, all the information in one place, and again, it's personalized and prioritized. So Joanne showed you this is the same patient. We used the same examples. Again, this patient, just to remind you though, this patient, for example, this patient's highest driver of their cardiovascular reversible risk is that they're a smoker. And so that's at the top. But then, again, the idea here is that this patient might say, I'm not quitting smoking. I'm not ready. And then the provider and the patient can then look and say, okay, well, what about your cholesterol? Can we take that on? And it gives the patient some agency in figuring out what they do want to try and manage to reduce their risk. And then again, as Joanne showed you, here's the CV Wizard provider view, which does a lot of great things in terms of saving providers time and putting everything in one place, and just helping again with some of that mental lift about like which of your risks is the one that I need to deal with the most. The recommended workflow, and this is relevant to some of the stuff I'm going to show you later, is again, this is at least how we did it at OCHIN, is that when in the rooming process, the wizard runs behind the scenes. When blood pressure is entered, wizard identifies patients age 40 to 75 who have diabetes or CVD, documented CVD, and one uncontrolled CVD risk factor or a high calculated total reversible risk. And we looked at 10% or higher risk, 10% or higher chance of having a heart attack in the next 10 years or stroke. The rooming staff see an alert, which you're seeing right here, the BPA that says, hey, CV Wizard has recommendations for this patient. And then the user can, with one click, view the results that I just showed you and print them with one more click. And you can also run it manually. The methods of the trial I'm going to talk to you about, again, we conducted this at OCHIN. We had 67 OCHIN members in 15 organizations. I should also shout out that we had 2 organizations that pilot tested it as well. So 17 OCHIN service areas have Wizard right now. And we randomized the clinics to intervention and control sites, where basically the intervention clinics had the tool for about 18 months. And the control clinics, at which point the control clinics did not have it, and then the control clinics got it turned on afterwards. I will say that we were fortunate that our comparison period ended right before the pandemic kind of made things really nuts for everybody. It was lucky for us that we were able to collect all that data without it being impacted. The implementation support that we provided to the clinics in this study was, we gave them a user guide, a kickoff training, exam room posters, wizard hats like mine, and a few webinars on how to use the tool, and then monthly use rate reports, as Joanne described. The primary outcome we were interested in was 1-year change in reversible risk. So we only included patients who from whom we had a year of follow-up data. So it was basically folks we saw in the first 6 months who we were then able to follow for another year. We also looked at change in blood pressure, LDL, and A1C for those who are above goal at baseline. And we did 2 different analyses here. This is really relevant to what Joanne was talking about before about the importance of adoption of a tool. We both did what's called intent to treat analysis, which says, well, if the tool had been used by everybody, what happens at the population level when the tool could be used broadly, and what was its impact when it was used? It's called effective treatment on the treated, or per protocol analysis, to say, well, so understanding it wasn't going to be used all the time, what happens when it is used? And we organized those results by looking at the tool being never used once, or used more than once for a given patient. We also looked at, was it ever used or never, or at all, versus a matched controls. We ran multi-level adjusted mixed models. We considered the tool use was at the index visit, the kickoff visit, where the tool was eligible for the tool use. And then we looked at all subsequent visits that was excluding the last visit in the follow-up, because there had to be some follow-up time, which is why the last one didn't count. And then we again stratified the analyses by patient's baseline reversible risk. Was it less than 10%? Total risk 10 to 20 or greater than 20. The reason we have some patients in there whose 10-year risk, I should note, is less than 10% is because they might have had diabetes or CVD and an uncontrolled risk factor, but not a 10-year risk. As I noted, there were 2 different categories of folks for whom the tool would alert. So here's some results. The tool was used about 1/3 of the time at index encounters, the kickoff encounter, though there's some variation there. When it was used about 2.4 times per patient. When it was used for a given patient, it was used more than once. But overall, of about 92,000 eligible encounters, it was only used, by which we mean viewed and printed, or a little bit just viewed without printing, 20% of encounters. This is exactly what Joanna's talking about, right? So the issue is, how do you have a population impact if the tool adoption is minimal? I will say a systematic review came out, I think this week, that shows that we are right in the ballpark here with what most decision support systems the adoption rates of most decision support systems. What Joanne and Patrick were able to get at Health Partners was substantially higher. We'll talk about that in a minute. Okay, so here is the impact of the tool. And I want to call out, again, these analyses are shown to you both broken out by intent to treat at the population level and at the effective treatment on the treated when the tool was used. So let me walk you through these right now. For all patients, overall, in fact, there was a slightly significant improvement for the control group. This is, again, though, not taking into account whether or not the tool was used. In reversible risk, it's a very, very, very small improvement, not very meaningful. And I guess I should just, in case it's not clear, a negative that's a reduction of 0.1% of someone who might have a 10% risk. There was no difference if you looked at patients in the lowest and highest risk groups, but in the medium group, again, looking at the whole set of patients, the controls actually did a little bit better than the intervention group. Again, this is not considering whether the tool was used or not. When the tool was used, this is the effective treatment on the treated. For patients whose baseline risk was less than 10%, no significant difference between the folks who had the wizard tool and folks who didn't. When the risk was higher than 10% and the tool was used basically just once, no significant difference. But here's where things get really exciting. When the tool was used more than once for a given patient, and all these three bottom rows, if the patient's reversible risk was greater than 10%, the intervention group did significantly better than the controls by improvement of about 2 percentage points. This is absolute improvement. For the group that's in the middle level of risk, again, a significant improvement among the intervention group, although it's a little bit less juicy. And in the highest risk group, so this last row is the real one that we found the most exciting finding. When the tool was used more than once among patients for whose risk was the highest, we get a significant improvement among folks who exposed to the tool. So this is a pretty exciting finding. It shows the tool works when used, mostly among the highest risk patients, and that's really important. So bear with me. We're going to talk about that some more. And I'll also show you what the impact was on the other measures we were interested in, the specific CVD risk factors. In intent to treat analyses, no differences for blood pressure, A1C, or LDL. But when the tool is used, and this is, we thought these are really interesting results. You actually, for diastolic blood pressure, there was a significant improvement in the intervention group. No significant difference for a systolic or for lipids between the two groups. And in fact, the controls did significantly better among those who had high A1C at baseline compared to folks who had wizard. And we think that's because most of the time the tool's going to be recommending a different, that the A1C management is not going to be at the top priority level. And I'll show you some more results that get at that in a second, and you'll think this will make a little more sense. We did just publish the results I just showed you in JAMA Network Open. This came out February 4th this year. And I just put the link to this article in the chat before I started talking. But now I'm going to show you some stuff no one has seen yet. This is not published. These are results we are getting ready to submit. So we were interested in saying, well, when was wizard used, right? We saw that overall it wasn't used as often as we'd want it to be. When was it used? And I think these results are really interesting and will lead to it. So I'm going to walk you through them. It was significantly more likely to be used when the patient had higher CVD risk, more than a 7.5% risk versus lower, but actually even, the higher, the greater. This is just how we categorize it for this analysis. It was significantly, quite a bit more likely to be used at a primary care visit versus someone came in for some other reason. Now that makes sense intuitively, but it's still interesting to see it play out. Significantly less likely to be used if the provider is running more than 10 minutes behind schedule. And here's the finding that I think really, for me, is the one that we sort of jumped up and down with excitement. If the appointment length was 20 minutes or more, versus less than 20 minutes or 5 to 15 minutes, 26% higher likelihood that the tool will be used, right? So this is, to me, this is a very important finding. And I'll talk about this more going forward. Another important finding is that the tool, that the longer it had been since the tool first went live and folks were first exposed to it and trained in it, the longer it was, the less likely it was for the tool to be used at a given encounter for a given provider, right? So it's been 5 months since the provider's been trained in the tool. They're not necessarily even remembering it. Like, it's hard to start habits, and then they're less likely perhaps to use it going forward. And it was also significantly more likely to be used in male patients versus female patients, which we thought was interesting. What was not significantly associated with tool use was whether it was a new versus established patient, patient age, patient race, ethnicity, patient insurance status, and clinic rurality. This is, again, was the tool used at all, viewed or printed. So soak that up. And then here, I'm going to ask my colleague Dave Boston to jump on and help me walk through this slide, because this is brand new results. These are, I should say, these are preliminary results, but we think they're really interesting. And I'm going to try and walk through these, and Dave, jump on in and help me out if I get anything wrong, please. What we did on this next analysis, and I should give a big tip of the hat to Annie Larson as well, who's been leading all these analyses on the OCHIN side, is we were interested in, what specifically, which recommendations did folks act on? So if a blood pressure medication was recommended, what happened? If a diabetes med was recommended, if a statin was recommended, or if smoking cessation referral was recommended, how did that play out? And what we're showing here is two sets of comparisons. First, we've got the intervention clinics when the tool was used. That's our reference group, compared to intervention patients when the tool wasn't used. So, and also compared to the control clinics. So here, I'm going to just show you here that for the blood pressure meds, when the tool wasn't in the intervention clinics, when the tool was not used, it was significantly less likely that someone would prescribe the recommended blood pressure med than if the tool was used. Quite a bit less likely. So that's showing, okay, this is how did we get the impacts we got? Well, in intervention patients, we were seeing more blood pressure recommendation if it was shown. And then the control clinics, not a significant difference. So interestingly, not a significant difference between the control clinics and the intervention clinics when the tool is used. We think that indicates what's going on is selective use of the tool for certain patients, and we're going to explore that more in the future. And then also interesting, we showed that Wizard could be at a higher or lower priority. So if it was, so again here, if for the blood pressure meds, if it was given as a higher part, one is the highest priority, not unexpectedly, but still interesting to see, the lower priority it was, the significantly less likely to be prescribed if it was the third priority versus the first or second priority. And we see a similar pattern play out with diabetes meds, where significantly less likely to get that med prescribed if the tool wasn't used versus if it was used in an intervention clinic. Not a significant difference, though, compared to the control clinics, compared to when the tool was used, again, as I said before. And then again, if it was a lower priority on the Wizard, it was less likely to be prescribed. Makes sense. For statins, though, we see something a little different. We're seeing that, again, that when the tool wasn't used, significantly less likely that someone's going to get a statin prescription than if the tool was used. Also seeing that compared to the control clinics, which is what we would have expected for the blood pressure and diabetes, but did not. But on a weird twist, if the statins were a higher priority, they were less likely to be prescribed than if they were a lower priority. And some of that is going to be because what's going to be at the top, as in the example we showed you for some, folks, it might be that smoking is at the top, is a top priority there. And maybe that's why, but we're honestly still trying to figure out what that is. And I'm going to ask Dave to speak to that in a second. But I'll just show you this last set. We didn't look at the priority for smoking cessation because if someone smoked, it was always the top priority. So that doesn't make sense to analyze. But here we did see the same pattern that we thought that, as with the statins, that when the tool wasn't used, significantly less likely to get that patient, for the patient to get that referral. And in the control clinics, compared to the intervention where the tool was used, same thing. So Dave, would you like to add any comment there on this slide? This analysis. Yeah.
Thank you. This, really fascinating and generates a lot of interesting hypotheses too. So one thing that's not shown here is that the BP and diabetes medications were much more commonly prescribed, even though, for instance, diabetes medication being number 1 or 2 was less likely to have occurred versus a statin, but they were much more likely to be given. So that, we think, is just that adding a blood pressure or diabetes medication is much easier than adding a statin, because we all know about statin resistance and getting somebody to quit smoking. Yet, that's where I think CV Wizard made its biggest impact. You can see that that it was really really showed a benefit compared to even the control clinics. And I think that's also this explains this priority paradox, because it's hard to get somebody to take a statin often. And the ones that were already priority 1 and 2 that have very high LDLs, likely somebody's already tried, and they've already been reticent to take it, or tried it once and had a muscle cramp or something and stopped. So we think it's easier probably to get somebody to take a statin if they never had one. But where CV Wizard, I think, makes a difference is in this shared decision-making part, where showing a patient and getting them to do these hard things like quit smoking and try another statin when they've been resistant, it really does, I think, have a benefit in that particular area.
Yeah. Thanks, Dave. All right, I've got just a couple wrap-up slides, and then I'm sure there's some questions, and I'm happy to talk about them. And thanks again, Dave. It's so fun working on this together, as you know. So just some high-level conclusions. The intent to treat results, where we saw improvements in the control clinics, but not the intervention, is certainly driven by the tool's low adoption rate. I mean, it's just totally diluted, and there were some differences in the two populations of patients. The effective treatment on the treated results do suggest that the tool benefits higher risk patients, and when the tool is used more often. We very much think that if maintained over time and used more broadly, there could be a clinically significant population level reduction in these events we're trying to avoid. We do need to do more research on how to get the tool adopted in the community health center setting. Just ahead, thanks to the Advance and BCORnet, which funds some of our data sources.
So thank you everyone for questions. And thank you, Dr. Sperl-Hillen and Dr. Gold, for that fantastic presentation.
Thanks for inviting me.
And thank you to everyone who attended today's session. Follow Health Partners Institute on Twitter at @_healthpartners, and check out their website at healthpartners.com. And be sure to follow OCHIN on Twitter at OCHIN Inc. and over on LinkedIn. In addition, head over to ochin.org and advancecollaborative.org to read the latest on our research studies, blog posts, and upcoming events. And don't forget to visit our OCHIN YouTube channel to catch up on our past Grand Rounds presentations. And stay tuned for next month's OCHIN Grand Rounds on April 14th as we welcome Dr. Natalie Huge and Dr. Heather Angier of Oregon Health and Science University as they present on the impact of the Affordable Care Act on community health centers. Invitations to this event will be sent 2 weeks prior to the event, but if you're not on our mailing list and are interested in attending this or any future Grand Rounds event, please email me at grandrounds@ochin.org. That's GrandRounds, all one word, grandrounds@ochin.org. So from all of us at OCHIN and Dr. Sperl-Hillen and Dr. Gold, to all of you, have a wonderful rest of your day and stay healthy out there.